check. Kalu. Kalu testing. Kalu. Check. Check. Kalu testing. Sound check.
Hello. Honorable dignitaries, electrophysiologists, cardiologists, EP fellows, residents, organizers, volunteers, and members from the industry. A pleasant evening to one and all of you. We feel privileged to welcome you to the third National Physiological Pacing Symposium. Here, we look forward to get an exposure about the theme Conduction System Pacing Simplified, which underscores a commitment to streamlining pacing techniques for enhanced efficiency in cardiac care. This resonates with a broad trend in medical conferences prioritizing simplicity and innovation in advancing conduction system technology. It is my pleasure to invite Dr. Ullasen Panurangi, Head of the Department, Cardiac Electrophysiology and Pacing, Madras Medical Mission, onto the stage for the welcome address and to inaugurate this evening, sir. Welcome, sir.
Good evening, everyone. It's a warm welcome from Madras Medical Mission Hospital to all of you to this third edition of the National Physiological Symposium. The theme of the symposium is the CSP Simplified. Last 2 years, I think we made CSP as a big thing, and from now onwards, we are going to make conduction system pacing science simple, understandable, and practicable by every implanting physician. The faculty has been chosen such that they are all passionate, all right, but they all want us to understand that it is not complex and the techniques are not complex. So that is what is going to be the activities from now onwards. And to begin with, we are going to have how far interesting or fascinating the CSP journey in the evening symposium today, and how was the MMM the part of this CSP journey. And tomorrow, we are going to have so many things. Will all be immersed in this conduction system pacing science and the implantation techniques. We have posted 3 live cases for demonstration, which will cover the spectrum of the utility of conduction system pacing, namely the Brady indication, second, CSP in heart failure, and most important is when you would like to upgrade any device with the aid of the CSP. And of course, the experts are going to be there during the implantation procedure, but I'm proud to say here, the star of the conduction system pacing in country, Dr. Shanmuga Sundaram, is going to be seen in action. And it would be a privilege to all of us the way he would do, and he would inspire us to take up this technology as a standard of care with respect to pacing. Thank you, Shanmuga. We have been so very proud of you, and you have put conduction system pacing landscape in the globe. And that is amazing work you have done. We will take you to the lab tomorrow, and before that we will make you to visit the wet lab, where the experts will show you the anatomy of the conduction system and why are those challenges you encounter during the implant. So that particular wet lab session, I request you not to miss. Gaurav Upadhyay is going to be showing it, and nobody knows as much as Gaurav Upadhyay with respect to the conduction system. Phenomenal work, research on the conduction system pacing, and then we're glad to have you, Gaurav. Gaurav is, by the way, is the professor of cardiology and electrophysiology. He actually leads the department in the University of Chicago School of Medicine. We will be going along with the journey when Zachary Whitney from UK, Imperial College of London, is with us. He's going to take us today through the journey of the CSP, and tomorrow we'll listen some great talks by him with respect to the selection of the cases for the his bundle, left bundle, and the techniques. Thank you so very much. We expected you last year, and you couldn't get the visa, but at this time, we closed down all the visa offices except one visa office of UK. You came to us here, and we remain grateful to you, and we wish that you continue to be associated with us. To respect that theme of conduction system pacing simplified, how about doing the conduction system pacing without this elaborate EP system? That's what is going to be demonstrated by the founder and the CEO of One Stim company from the US, Dr. Michael. Thank you for coming, and please don't miss this demonstration of how you can do the CSP with a small portable tool, and you have everything what you see in the EP lab integrated into that tiny, cute system. So please do not miss that. We will be also listening to some talks which will be delivered online. One of the highlights of the symposium is very emotional and an inspirational talk by the inventor himself, Dr. Benjamin Sherlock. He will give us the first-hand experience. He himself underwent CSP to the science to which he had contributed so significantly. So it is very nice of him. I request you people not to miss Sherlock's talk, and I'm sure that would be absolutely inspirational. We have several of the talks, and those are all interspersed in the live demos. We have some more foreign faculty online. When we listen to that, we will be inspired how this technology is evolving. We have Michael Chami from Atlanta, who is going to be talking about leadless pacemaker as a part of conduction system pacing. So all that technology, what you are going to be seeing today, may be obsolete soon. I mean, why we should have leads for a conduction system pacing. And that's going to be, again, a very innovative idea. And I'm glad that we are going to be listening to him. Finally, we have the person. Such persons exist, and that is why we practice. And who are those? The engineers who know the science much more than all of us. And the industry is actually putting a lot of their resources to make CSP globally accepted. And I'm glad to have Dr. Ping, who is the engineer representing Medtronic industry. He was there with us in the morning today. I was fortunate to see for the first time in the country how Medtronic is progressing, and that is beautiful. I mean, how about even the defibrillators leads for a conduction system pacing? That is where it is leading up to. So, ladies and gentlemen, without much more to say, may I now invite, well, we don't have seats here, but Dr. K.K. Sethi. Let's give a big round of applause. We don't have a chair here, sir. Okay. Ladies and gentlemen, Dr. K.K. Sethi is not only patron for me, he's the patron of Indian Heart Rhythm Society. He was the professor at the most prestigious cardiac institute of the country, G.B. Pant. And I have no hesitation to say that he laid a very strong foundation for the electrophysiology science in the country, and his contribution is immeasurable. He had been the past president of the IHRS. He continues to be patron of Indian Heart Rhythm Society. And if our society is growing, is because of his wisdom and his support and the guidance. And one of the reasons why I became the Indian Heart Rhythm Society president is because of you. He's saying, so would you please say that to the public? So I was lost for the words when I took the position of the president of Indian Heart Rhythm Society. I was lost for the words. Professor Sethi wrote my speech. In his own notebook, with his own pen, he wrote it. And it was very difficult for me to by heart that. His language is superb. He's the most distinguished speaker in the field of electrophysiology in the country. Sir, thank you very, very much. So, I would request him to make some opening remarks when I call up Zachary Winnett, who will take us to the fascinating journey of conduction system pacing so far. So I leave the dais now. I invite Zachary, the most distinguished electrophysiologist and widely known for his skills in conduction system pacing. So, Dr. Zachary, would you mind coming over here and start your speech? And before that, sir, come to the dais and few words about the whole thing. After Zachary's talk, Gaurav, you make some comments. And after Gaurav's, Dr. Ajit. Dr. Ajit is the backbone of everything that happens in MMM. And today only Gaurav also appreciated the kind of freedom, what the EP department receives, the encouragement, the kind of encouragement I receive from him. Sir, I remain grateful to you. So you would be making the final remarks. So, sir, thank you.
Thank you, Ulas, for inviting me here, not only to the meeting, but also an unexpected trip to the dais. And he just told me a few minutes ago that I have to give some opening remarks. So anyway, I'm very delighted to be here. And I have met so many old friends, including Ajit, who just entered. And it's my pleasure to be here. And what I want to say is that the quest for physiologic pacing is actually not new. And it's a journey which actually began a few decades ago. I remember in 1981, when I did the first dual chamber pacemaker of India, there were no atrial leads. And I actually started from an AAI system in a patient with sinus node disease who happened to be a doctor's mother. And since I had no formal training in putting atrial leads, I slept in the patient's room in the ICU to make sure that the lead, if it displaces or something happens, I will be able to take care of it immediately. Otherwise, I will be answerable not only to the head of the department the next morning, but also to the director of the hospital. But anyway, and then the dual chamber pacemakers started in around that time. And we also started doing them in GB Pant in the year 1981 itself, late 1981. And that was the physiologic pacemaker. It was called the physiologic pacemaker. We started with VDD. I remember Anatrax from Medtronic 7100 is the model. It was a unipolar device. And later, the perils of right ventricular apical pacing were realized many years later. And the competition between single and the dual chamber pacemakers, particularly in sinus node dysfunction, and whether or not dual chamber pacemaker really provided any extra benefit in terms of survival and other things, was continuously debated. And then several decades went by. Every 20 years we get an innovation, roughly. That is what I think. And in the late 90s we got these biventricular devices. And that initially was called bi-V pacing, and later cardiac resynchronization therapy, to which later the defibrillator leads were added. And then that became the physiologic pacemaker of that era. And since then, another 20 odd years have passed when conduction system pacing has now come up. A few years ago, we started with his bundle pacing, and a huge experience was actually gained in China. As the earlier implanters across the globe, I think in some years ago, if I don't forget the figures, they had already completed 50,000 his bundle pacemaker implants in China. However, the definition of physiological pacing, I think, is still work in progress. It is still evolving. And from his bundle pacing, we went to left bundle area pacing. And then the comparison with cardiac resynchronization therapy is going to come. And there will be a test in time for us to see that the initial enthusiasm, which is based mostly on retrospective observational data comparing left bundle area or his bundle pacing with CRT, actually proves itself to be superior to expectedly. It is expected to do that because of the mechanisms by which it stimulates the heart. But unless we have some more randomized data, it will be hard, because surprises are always there in science, and we have all seen them happening. So with these remarks, as I said, this is still work in progress, and I'm sure there will be leadless pacemakers coming in for conduction system area pacing in near future, and we'll see many more innovations to come. And it's a very pleasant evening today. Thank you so much, Ulhas, for putting this together. And we have some starred speakers from across the globe who will be taking us through the journey of this new science. And it will be our pleasure to listen to them. So thank you very much and welcome once again.
Thank you. I'm ever so pleased to be here. Only 1 year late, and it's a fabulous meeting, and thank you very much for the invitation. So my job this evening is to give you a fairly quick summary of the journey of conduction system pacing. These are my potential conflicts of interest. So the journey starts, of course, with the conduction system. And as we all know, the heart has evolved over millennia to have this highly sophisticated conduction system. And normal heart function depends on a normal functioning conduction system. And the difficulty is, of course, like any other organ, the conduction system, the heart and the conduction system in particular, is susceptible to having disease. Now, the disease can infect the conduction system and cause bradycardia and AV block, which adversely affects cardiac function by reducing cardiac output. It can cause PR prolongation, which can adversely affect filling, again, adversely affect cardiac function, and it can lead to inefficient ventricular activation by causing bundle branch block, and that again leads to less efficient cardiac activation. So the original reason for developing pacemakers was in patients who developed severe bradycardia, which caused profound reductions in cardiac output and symptoms. And pacing therapy was a major step forward. And the initial way for delivering pacing therapy was by directly stimulating the myocardium with RV myocardial pacing, which has immediate beneficial effects. So you're able to immediately increase cardiac output and make people feel better and improve symptoms. And right ventricular pacing is a very effective way at preventing bradycardia. But of course, it doesn't restore normal physiological activation. That wasn't too much of a concern initially, because the major step forward was to take patients who had very, very low cardiac output as a result of the severe bradycardia and immediately improve cardiac output. So we were making people feel better. But it's subsequently become apparent to us that this non-physiological ventricular activation can have important consequences. So the David trial very famously showed us that if you delivered RV myocardial pacing to patients with pre-existing ventricular impairment, that this had severe consequences and that it could increase the risk of death and heart failure hospitalization. So that desynchronous, non-physiological activation, the deviation from the normal physiology, had important consequences. And not only that, in the MOST study, we found out that basically patients who had pre-existing normal ventricular function could also have adverse consequences from this non-physiological activation, because they obtain pacing-induced cardiomyopathy. So the RV myocardial pacing could be the trigger for the decline in ventricular function. So this led to a drive and to try and avoid pacing-induced cardiomyopathy. And the first innovation forward was, of course, biventricular pacing, which was originally used to treat left bundle branch block, but in subsequent studies, it was investigated as an alternative to RV myocardial pacing. Now, biventricular pacing in block HF, which was patients with AV block and an EF of less than 50%, was associated with an improvement in outcomes. But it may not be the optimal way to mitigate the impact of ventricular pacing, because biventricular pacing, of course, doesn't restore normal physiological activation. If we deliver biventricular pacing to a patient who has narrow QRS, we actually lengthen the total activation time. So in a patient with a narrow QRS, biventricular pacing actually causes electrical desynchrony. And not only that, it doesn't restore normal ventricular activation patterns, because we're still relying on cell-to-cell activation. You can see there's two wavefronts from the two waves. Yes, it's better than RV pacing because we pre-excite the left ventricle, but it doesn't restore the normal rapid physiological activation that we see in when the conduction system is intact. And this non-physiological ventricular activation is important. Echo CRT trial showed us that if you deliver biventricular pacing to patients who've got pre-existing ventricular impairment and a narrow QRS duration, that unwanted lengthening of activation time was associated without adverse outcomes, actually increased mortality. So biventricular pacing probably isn't the best way to deliver physiological pacing. So, of course, the natural place to turn to is the conduction system. So the heart has this sophisticated system for ventricular activation. Why not utilize it? And there were early studies, even in the 1960s, which showed that you could overcome bundle branch block by pacing distal to the level of block. And the first area we targeted, as we've heard already this evening, was the His bundle. It makes sense, it's a proximal location, and allows us to stimulate the, to achieve physiological biventricular activation. And in 2000, Dr. Deschmuck published the first report of permanent direct His bundle pacing. He took, and this was in a group of patients with heart failure and who had atrial fibrillation and were going to have AV node ablation. And he did this without dedicated tools. This was done with modification of the lead of existing stylet-driven leads without any delivery systems. But despite that, and with his perseverance, he was able to stimulate the His bundle in quite a large number of the patients, so 12 out of 18 of the patients he was successfully able to achieve His bundle pacing. But it was difficult. It took time, didn't have dedicated tools, but nevertheless he demonstrated feasibility of the conduction system as a target for pacing therapy. As following on from that publication, there was it was seen as still as a complicated and difficult procedure, but gradually, and this is the number of publications per year, it's a slightly old slide, but what it shows was that there was a gradual, slow uptake of pockets of interested physicians around the world who liked the concept of conduction system pacing and began to trial and take up the technique. The whole story of conduction system pacing really starts with the physicians. It's not been driven primarily by industry, it's been driven by physicians trying to do the best for their patients. We recognize that the conduction system is the most efficient way for the heart to activate, and that's the whole story has all been driven by physicians taking up. But of course, we don't work in isolation, and we work with industry. The initial work rapidly moved on to using the 3830 lead, which of course is not a lead that was designed specifically for His bundle pacing or conduction system pacing, but had some features which made it potentially attractive, given that it was a luminous lead with a small French size. And the first dedicated sheath was the C304, which was a deflectable sheath, but didn't have any sort of septal curve. But it nevertheless made the delivery of the leads to the His bundle area possible. The next innovation was the C3105 lead, which the important innovation was that it had the septal curve to allow delivering the lead to the septum more straightforward. And this is a nice slide by my good friend Francesco Zanon from Italy. And essentially what it showed was that having dedicated tools did make an important difference in terms of implant success rates as well as the procedural endpoints. We could see that the capture thresholds became lower when we were able to more easily deliver the lead to the His bundle. So one of the things that's driven us on just through these in more difficult early years was the fact that the electrical response was so immediately, obviously, to see that it was we were achieving what we were trying to achieve, namely capturing the conduction system. So a His bundle pacing ECG, you can see shows a beautiful narrow QRS complex. If you've got pre-existing conduction, you can see that the ECG often looks identical to the intrinsic ECG. So we must be doing something good. It's very different to the very non-physiological looking ECG of RV myocardial pacing. And if we look at with more fancy maps, we can see that the activation patterns that you get with His bundle pacing is identical to that achieved with doing normal physiological intrinsic activation. And this more physiological pacing was investigated, and Francesco Zanon looked at coronary perfusion and found that coronary perfusion was preserved with His bundle pacing compared to RV apical pacing. So early physiological data suggesting that that this improved electrical activation actually leads to improvements in cardiac function. We found that looking at with high precision acute hemodynamics that compared to RV pacing, His bundle pacing delivers an immediate improvement in acute hemodynamic function. So the electrical function seems to translate into cardiac pump function improvements. Now, of course, it's no good having a technique which looks nice and gives you a nice ECG, but it's not feasible and it's not safe. So in 2019, there were two relatively large series, one the Anglo-American series and a European series, looking at the safety and feasibility of His bundle pacing. So the implant success rates, and bearing in mind many of these patients were actually during operators' learning curve, showed that there were relatively high implant success rates overall, about 81% in our study. But implant success rate improved with operator experience, and it looked like the learning curve of about 40 cases, it began to flatten off a little bit. Capture thresholds were higher than compared to the RV myocardial capture. And one of the things we identified from these observational studies was that the need for reintervention was in the region of 6 to 8%. So that's higher than what you'd see with standard RV myocardial pacing. Of course, RV myocardial pacing is not without complications. And obviously the complication we're trying to avoid was pacing-induced cardiomyopathy, but there are, of course, need for lead revisions of RV pacing. But this was the driver for thinking about other sites in the conduction system. But before we think about that, what about clinical outcomes with His bundle pacing? Is this more physiological activation leading to improved outcomes? So we haven't yet had a very large randomized controlled trial, but Pugal Vijay Raman published this very nice study, in fact groundbreaking study really, which was an observational non-randomized cohort study looking at in patients with a bradycardia indication for pacing between the two hospitals within his healthcare system. They looked at patients who received His bundle pacing versus those that received RV pacing. And the big headline was that overall, the patients who received His bundle pacing had fewer of the primary outcomes, which were death, heart failure, hospitalization, or need for upgrades to biventricular pacing. So, of course, we have to take this data. It's not a randomized controlled trial, but it gives us some encouragement that more physiological pacing may actually lead to improved outcomes. And as you'd expect, the group that benefited most were those that had the highest pacing requirement. In terms of prospective randomized trials of his-bundle pacing in the bradycardia field, there were relatively few. The HOPE-HF study was one that we conducted, which looked at a particular group of patients, so patients with a long PR interval and heart failure. But we recruited patients, and really this is the largest prospective study at the time of his-bundle pacings. We recruited patients with an ejection fraction less than 40% and a long PR interval, and either narrow QRS or right bundle branch block. Our primary outcome was whether there's an improvement in exercise capacity. And we recruited 167 patients from a number of centres in the United Kingdom. And what we found was that actually, even though quite a few of these implanters were being trained at the time in his-bundle pacing, the success rate, the acute success rate was 93%, which we were quite happy with. The capture thresholds were about 1.33 volts. So implants, it showed that his-bundle pacing, despite the mantra at the time from many was that it's not it's too difficult, operators can't do it. It showed that it was technically feasible in a prospective setting. We didn't find in the group as a whole an improvement, a significant improvement in peak oxygen consumption, but actually in this group of patients it made people feel better. And this was assessed in a double-blinded way. But what was really key was that actually what we showed for the first time was that in a group of patients who got impaired ventricular function and a narrow QRS, there was no sign with this pacing modality that we were adversely affecting pump function. So conduction system pacing, with his-bundle pacing in this case, actually seems to be a safe way to deliver pacing, as opposed to right ventricular myocardial pacing and even biventricular pacing in this group of people. But of course, I've mentioned some of the challenges of his-bundle pacing, the higher capture thresholds, and the need for lead reinterventions. And this led to looking at alternate conduction system pacing sites, and in particular the left bundle. Professor Weijin Huang in China reported, and he developed this technique for delivering a lead through the interventricular septum to capture the left bundle, and he first reported the case report of this in about 2019. And what we found was that with left bundle pacing, you could deliver, again, very nice looking ECG, very rapid ventricular activation, but we did see this typical R prime in V1 because there appears, because of the more distal, because you're capturing the conduction system more distally, there is slightly delayed right ventricular activation. He then published a case series of 630 patients, so observational data, so looking at the feasibility and safety of left bundle pacing. And the findings from this were really exceptionally encouraging. So very high implant success rate, of course, very experienced operator. But what was really encouraging was that the capture thresholds were very low and stable. And R-wave sensing, typically very good. So left bundle area pacing seems to overcome two of the challenges of his bundle pacing. One of the concerns initially was that we may be causing tricuspid regurgitation, maybe we'd interfere with the tricuspid valve leaflet, but this early publication didn't find that there was much evidence of significant TR, at least acutely. This was followed by a even larger registry of pacing, of left bundle area pacing from Europe, about 2,500 patients. Nearly 70% had a bradycardia indication, pacing indication, And what this gives us further evidence about the safety and feasibility, but also the practice of, in terms of where the leads were being located. Professor Huang's technique, his aim was always to capture the more proximal left bundle. But actually what we found in the MELOS registry is that the left bundle there's quite a lot of the left bundle that we can target, and actually in practice in Europe at least, we're often targeting the slightly more distal conduction system rather than the very proximal conduction system. Overall, safety was good. Now, we reported everything here, and you might say 8.3% lead complication rates is high, but lots of this was due to acute perforations during the procedure. So no real clinical indication. As long as you recognize that, it's not going to cause any long-term issue. Now, there are potential for complications in terms of that are specific to left bundle area pacing, such as septal hematomas. But overall, this was demonstrates again further evidence of important feasibility of this really exciting technique. And then what about outcomes? Here's a further observational study from Dr. Sharma and Dr. Vijay Raman, which again compared patients in a non-randomized fashion with a bradycardia indication for pacing, to see whether they got, so patients were followed up depending on whether they got left bundle area pacing or RV pacing. And similar, the findings showed that QRS duration, very nice, in the left bundle pacing group compared to the RV pacing group. And outcomes very similar to Dr. Vijay Raman's initial findings with the HIS bundle pacing, that overall the primary composite of all-cause mortality, heart failure hospitalization, was reduced in the left bundle area pacing group. So this is all very, very encouraging data. But of course, we need, if we truly want to know whether conduction system pacing is more, is associated with fewer complications, we need randomized controlled trials. And there are now, I'm pleased to say, a number of randomized controlled trials that are ongoing. So they vary in size. There are a number of trials that are looking at primarily echo criteria. These trials are now recruiting. But what's interesting is that these trials are generally not funded by industry. They're funded by charities, local research institutes, but these are now recruiting. We're recruiting for the PROTECT HF study in the UK, which is funded by the British Heart Foundation. We're going to recruit 2,600 patients, and our inclusion criteria are patients who have a bradycardia indication for pacing, and we expect they're going to pace more than 20%, which so we're looking at patients with an indication AV block, essentially not including patients with sick sinus syndrome. We've recruited now nearly 300 patients for this study, so we are making very good progress, still getting people on board. So this will give us, and the difference between this study and the other studies, that our primary outcome here is mortality and heart failure hospitalization. So this will hopefully be the definitive study, but obviously it will take time. So, conduction system, where are we at in the present day with conduction system pacing? Well, on the basis of the really encouraging results from our observational data, there is now a huge global rise in the number of CSP implants worldwide. And I expect this is just going to carry on increasing. We've now got CSP adopted into guidelines. The European guidelines, we have HIS bundle pacing in patients who are anticipated to have high ventricular pacing burden. CRT I haven't really mentioned. We're going to talk about it in other talks, but again, it's It's accepted as an alternative if you have failed biventricular pacing. The more recent American and APHRS guidelines are even more give even more options for conduction system pacing, both for bradycardia indications as well as for CRT indications, mainly as in the case of failure. So the big step forward now, after years of us asking and trying to encourage industry, is that industry is really actively investing now in developing new technology for conduction system pacing delivery. All the manufacturers have some form of CSP tools available, which is making our lives easier. We still don't have yet dedicated conduction system pacing leads, but I know that pretty much all the manufacturers are working on this or have aims for this. So this is being driven again by us as physicians wanting to deliver it and demand, and of course the data that's out there. So what about CSP in the future? Of course, we eagerly await the outcomes of our randomized controlled trials, because if they are positive, then CSP will become first-line pacing modality. And that will then reach beyond enthusiasts like us, the ones that are here in the room. This will then transform pacing practice. So people who are implanting pacemakers, I think, will be encouraged to, or probably mandated to attempt conduction system pacing. I think, and we've already touched upon this, there are going to be hopefully further technological advances. We need to make this implant even easier and more feasible. I'm going to stop there, and I look forward to the rest of the meeting. Thank you very much. Are we doing questions, or are you going to Gareth come up and talk?
Thank you so much, Zach. Thank you so much, Dr. Panduragi, Dr. Ajit. Thank you to the organizers as well as Medtronic. And thank you to all of you who are here today with us this evening. Just by a show of hands, how many of you are practicing electrophysiologists? Would you say that you're a practicing electrophysiologist? Okay. And how many of you would identify yourself as a practicing interventional cardiologist? Okay, that's fantastic. And how many of you are trainees, either in fellowship or in residency? Okay, great. And then how many of you are either working in the lab or technicians, somehow other work? It's everybody, right? Okay. So what is so exciting about this is that you're really here because of your commitment to your patients and the commitment to understanding what is happening in the field. What's driving this is not a new technological breakthrough that is a paradigm in the market. This is actually a deeper understanding of the science of electrophysiology. And what makes electrophysiology interesting is that it's physiology. And I'm especially happy that the interventional cardiologists are here, because many of you are in the front lines putting in pacemakers, and you're serving your patients better by understanding how the field of pacing is changing. So that's very exciting, and it's such a really wonderful opportunity to be here with you. I just wanted to share a very short story. We're going to hear from Dr. Sherlag tomorrow. Dr. Sherlag is credited with publishing the first human His recording. He was actually not the first person to make a human recording of the His. That was actually performed by Dr. John Lister and Dr. Ankur Narula. Dr. Ankur Narula actually later on and described the first correction of left bundle branch block with physiological pacing. And I only mention that to say that Dr. Lister and Dr. Narula actually presented their findings in 1968, but they were so interested in the work and the practical work of taking care of patients and doing the science that they also didn't necessarily publish. Now, Dr. Shinmuga is an incredible example of someone who is both practicing and publishing, and I will tell you that I'm so impressed by the amount of work that all of you are doing, really taking care of patients. For those of you who have an interest and who have an inclination to try to push the field, this is an incredibly democratic time in pacing. This is truly a global experience in pacing. And all of you, as practicing physicians here in India, can meaningfully change the field of pacing. I think that we're going to see big changes in the next 10 years, and you can also be a part of that. And Dr. Shinmuga has already really done an incredible example of that. So I'm so excited for these next few days because we're going to get into the actual nitty-gritty of pacing. By the end, my hope is that all of you look at a regular RV-paced electrocardiogram and just grimace in pain and say that this is not, not what we're going to accept. And also have curiosity when you see changes in the electrocardiogram that you did not expect when you put the lead in a location that you expected to find. The goal, of course, is to deliver the best care that we can for our patients. So thank you very much, and thank you to the organizers.
Thank you, sir, for giving us your valuable insights. I now request Dr. Ulasem Pandurangi to deliver his talk on Triple-M's journey of conduction system pacing.
Thank you, Gaurav. It is you who had inspired so many of us. And at my institute, it's like almost 100% conduction system pacing. Not only me, none of the interventional cardiologists would like to see that wide QRS because of the RV apical pacing. Thank you, Dr. Vinette, taking us through the CSP journey so far. And it's my privilege to take you through the journey, what we underwent regarding the conduction system pacing at my institute. How do I put the slideshow on here? I think I got it. No? No? Resume the slideshow. Is that down? Oh. It's okay? It's okay? See, our journey of conduction system pacing at the Madras Medical Mission Institute began during a casual talk with the director of my institute, Dr. Ajit, and Dr. Ram Kumar, who is the device specialist of my institute. It was in the corridors 2018 when just the publications were coming up. We actually discussed in the corridors the astounding works of Dr. Pugalindi, who is considered to be the guide for the CSP training in India. And of course, Shanmuga and him, as you said, incredible work. And then we looked at Ellen Bogan and Parikshit Sharma, his prodigy. And of course, Vaijan had just then published his left bundle. So we just were looking at the ECG, what was the result of the conduction system pacing. And then if we were not to be inspired then we were not the true doctors. So it was a casual talk, and then the journey began. So we thought of bringing in some experts, and a handy man was Ellen Bogan's prodigy, and that is Parikshit. So he came, visited India for the first time regarding the CSP program 5 years back in January 2019, and India saw the first ever time the live demonstration of conduction system pacing. Very few audience, but from across the world, across the country. And then, thanks to Medtronics, they have been very supportive in this program of conduction system pacing education. And this is the third time unrestricted grants they provide to us. And I remain thankful to them, and then I hope we continue this kind of a program every year. So it was in 2020, the first National Physiological Symposium took place. And another prodigy of Ellen Bogan, late Santosh Padala. I think it was probably his last of the overseas live demonstration. We had been fortunate to have him with us in action. And if at all in that crowd, there was somebody who was completely immersed, and he the guy who thought not to be missed any single word or a sentence is this man who was the rising star then, and he's such a shining star now. I take pride that MMM inspired Shanmuga. And then he has always been a good friend of us, and he's always there whenever there's an education program, Shanmuga. So then there was the first time when the deflectable sheet from the Medtronic was being launched. We have had this great person, Puglindi, to come down and teach us, and then we had some live demonstrations of these deflectable sheets for the conduction system pacing. That was in 2022. Dr. Ajit, as usual, has been there throughout these kind of education programs, and today this is all successful because of his support, unrestricted, and his encouragement. And then the second symposium also saw from the European side, and that is Haranburi. And he demonstrated various techniques which we learned how to make it more simplified. It is during this time we missed Zakari. We really wanted you to do that time, but anyway, you came this time. So Haranburi, I think, more than compensated anybody's absence. We see Daljit sitting there. And then she probably is looking at what he could have said better. Daljit? Yeah. So then there was this company, Abbott. Abbott wanted to plunge in, and then they brought their tools. And we take pride that we introduced in the country their technology. And that was with the Agilis His Pro, now that they have brought in some easy-to-handle kind of devices. And at that time, we had another expert from the eastern part of the world. Tan Boon came. And the way he implanted, of course, he is a left bundle area pacing man. And he took that sheath, which is really big and hard. But then, if you want to do the left bundle area pacing, he showed how do you reshape that. And then we learned it, and then we have been doing it, even though it looks like Abbott is phasing out that sheet, which is a sad thing to understand, because that is the sheet which we think is actually made for the conduction system pacing, because it has an electrode inbuilt and the mapping is easier, and maybe the injury is less. So Biotronic was not staying behind, so Biotronic came in. And then we take again pride in introducing the Biotronic technology in the country. They came in September last year, and then we have had this particular conference saw the interventional cardiologists. Majority of them are interventional cardiologists. So I'm thankful to some of those here who practice mainly interventional cardiology for attending this. It simply says that they were inspired. So many of the interventional cardiologists got inspired when Tan Boon and come and then this technology was introduced to the interventional cardiologist. As I was mentioning, it's like almost 100%, at least for the Brady pacing, whether it is a narrow QR escape or a wide QR escape, whatever, Brady indication, it's like 100%. And we have experience across all the companies. And well, we actually try to do more for his bundle pacing, which we consider it's actually physiological. We spend time. Dr. Ajit allows us to occupy the lab as long as it's possible. And his bundle pacing cannot be done in a lab, which is very busy, and then that lab is also shared by the interventional cardiologist. So we spend more time because we believe that kind of a QRS with the his bundle pacing, left bundle area pacing cannot achieve. We do not go to the left bundle area pacing if there is an intrinsic narrow QRS escape. We don't really go into the left bundle area. We strive, and only when 25 to 30% of the times we are successful, whether it's a narrow or a wide QRS escape rhythm. We have done right-sided, not only with the Medtronic, even by Biotronic. So just because the left axis is not okay, we don't get disheartened. We tend to complete physiological pacing with the right-sided. The theme of this conference is to make CSP simplified. So that is there in our mind ever since we started, because this elaborate EP system is what makes the interventional cardiologist to go away from that. So in the context of the CSP needs to be simplified, we are doing, and my colleague Anbarasan is very passionate about how to do this without the EP system. He has his own project, and then he's almost always he does the CSP with a great result and demonstrating that it's actually conduction system capture, not necessarily utilizing the big EP lab. So he had done some cases across all the companies, and I think it is feasible without truly looking at the intracardiac electrograms. Our MMM is known for its remote monitoring, and we believe in those patients whom we have given a CSP, we should do better care, because there are certain issues which could be monitored, especially when we are doing more often the his bundle. We are looking for the morphology, we are looking for the thresholds remotely. So I think remote monitoring also helps. That is what we have shown through this journey of a CSP at our institute. As I said, Michael has come here. Tomorrow he's going to be showing this particular system, and Anindya is the head of this particular project, where we are going to be blinded to, we will have an EP system, but the person who is onto this system is blinded, and then we are going to be looking at it, whether it is feasible. CSP in the pediatric age group, I think MMM has the largest of the volume in the country. And Dr. Shivakumar, is he around today here? Well, he's again busy doing a conduction system pacing for a complex congenital heart disease, I think. I mean, he doesn't also use the EP system, but if you look at the result with respect to the QRS morphology, I think definitely it is much, much better than the RV apical pacing, and especially his patients are sick. They are complex congenital heart diseases. Today, I think he has the largest data about the CSP utility in the pediatric age group. Anindya had been the backbone of my department, a brilliant electrophysiologist in making, a prolific writer. So ever since he joined us, we made some publications, including the largest of the series from India with respect to the stellate-driven leads. We have made not necessarily publication of a large series, but several case reports. And most important thing, my department is not known, definitely as you know, because of me. it is because of the technologists, the physician assistants who have been working for the department. Each one of them have contributed to the literature, and that I think no institute in this country has done. The cardiac technologists and the physician assistants have contributed significantly to the academic activities of our hospital. So I remain thankful and grateful to all of you. And India has a list of projects in his hands, and he had spoken to Gaurav, and we are looking at the randomized data across all the companies, and I look forward to your continuous guidance and analysis of what we have done. So I strongly believe conduction system pacing is the future of pacing, as Gaurav said, and MMM is consistently making its efforts to simplify this procedure for all the implanting physicians who are transitioning to this strategy. Thank you.
Thank you so much, sir, for sharing your valuable thoughts on the future of conduction system pacing. Louis Pasteur once said, "Science has no country because knowledge belongs to humanity, and it is the torch which illuminates the world." It is on occasions like this we get opportunities to better our knowledge and understanding. Having said that, I take this opportunity to invite the gathering for the open house discussion.
Thank you, Ulas, for holding this meeting consecutively with good science behind it. In MMM, I think that conduction system pacing is passionate for all cardiologists, not electrophysiologists. And you can see very quickly that what Ulas said is that Shiva is the largest pediatric, every structural heart which undergoes a TAVR, which requires a pacing, gets his bundle pacing. Every case which, we need help from each other. I was very happy when Gaurav said that you use the rotaglide infusion for sometimes catheters to get through for smoothness. We use microcatheters if you want to get down to difficult areas. And I think it's really the group of people working together to deliver the care which makes the difference for high quality care. I'm extremely happy that, a lot of my old friends are here and who have come here from all part of the country to discuss this important area, because I strongly believe that physiological pacing is conduction system pacing, and I think we should get it to all patients. The only thing is 90% of these implants of pacemakers are done by non-electrophysiologists in this country, and we need to make it simple. And I think the simplest thing is just get a good ECG, which doesn't look odd at the end of the pacing, and nobody likes to see a right ventricular pacing being done. In my opinion, as an ECG. So I think this 2 days will help us to learn a lot about how to simplify it and make it available for everybody. And I also like to thank all our physicians. And just for, we published the largest number of publications in this country from cardiology, 160 publications last 4 years, including major journals like JAMA, JACC, Circulation, European Heart Journal, and many other major journals. And I'm very glad that the electrophysiology department is doing the same. So thank you very much for coming, and I'm open these questions to everybody. If they have any questions, we've got the best group of people here who can answer us. And thank you, Dr. Sethi, for coming, Dr. Gaurav, Zach, and all the other international faculty for this meeting. Please go ahead with any questions.
thought this is rather a good opportunity to ask that question from the experts. That is there a large body of experience about post-TAVR heart blocks and conduction system pacing?
Maybe we can both take a component of this question because this is a really wonderful question. Post-TAVR ECG changes, let's first examine that as an area. Post-TAVR left bundle branch block has been very well described, and that's because the struts of the TAVR itself apply mechanical pressure on the proximal portion of the left bundle. And in fact, if you have a left bundle branch block post-TAVR, there is a higher risk of later progression to complete heart block. This is actually also a really wonderful natural experiment of mechanical proximal left bundle branch block. And we are developing newer criteria to really parse out what the pattern is that we see on the ECG, and does it reflect proximal versus more distal myopathies. So you'll see a publication soon from our center looking at ECG criterion for left bundle branch block. Now your question had to do with the use of pacing in TAVR patients, and initially that was really well described with His bundle pacing, but there was concern with threshold rises with His bundle pacing post-TAVR because of further progression of more distal disease and block. And now there has been a general shift to left bundle branch area pacing for these patients. So I think that many times that's now a preferred modality for post-TAVR.
Yeah, no, I agree. There's not so much to add to that. But the nice thing about the TAVR indication was that we knew where the level of block would be. With His bundle pacing, many of us were a little bit concerned, particularly in the acute setting. So in the acute setting of putting a His bundle lead in, and then as Gaurav said, then you having progression and capture distal to where you have the lead. But with left bundle area pacing, it's a very nice technique. You can make sure you're definitely distal.
About a half away from the His bundle area.
Yeah, and as we'll go on to talk tomorrow, the left bundle as well, we can target in different locations. So we can go proximal left bundle, or in many cases people are targeting more distally. So I think we can safely say we can deliver a lead to the conduction system distal to the level of block. And these patients are unlikely to develop more distal disease. It's an iatrogenic block,
And I would say for any of you who are doing this routinely in practice, the struts of that valve are a great anatomic reference. So you don't need a His lead, you don't need anything because you have the struts of the valve itself. So when you examine the struts of the valve in RAO and LAO, you can, in your mind's eye, imagine the course of the left bundle, because the left bundle will emerge just beneath the struts of a TAVR valve. So it's a great anatomical reference.
Yeah. If you see left bundle branch block after a TAVR, how many days later have you seen complete heart blocks coming?
The event rate is low, but they have been as late as 30 days reported by the Colorado group, and looking at longer term monitoring of these patients. The event rate is generally considered between 2 and 6% for late progression. So 6% is obviously a little bit on the high side, but that's actually what led to the change in the guidelines having to do with pacing. Normally we say you need to have some evidence of intermittent block to justify a pacemaker, but a new left bundle branch block in the American guidelines is a class 2B indication by itself to proceed with pacing. Now, I haven't seen in our center, I'm not sure if you've had, where very late block I think is unlikely, but within the first 30 days we've certainly seen it.
Yeah, that's our experience as well. Very late block, unlikely. But if they've got ongoing left bundle branch block, these patients are often quite frail. Their ventricles are often not ideal. So actually, the developing the left bundle branch block and the desynchronous activation is often not helpful in those patients. So my practice is if they've got ongoing left bundle branch block and some degree of LV impairment, actually putting a conduction system lead in that situation, you're going to help the overall function, and then obviously if they are somebody who gets the late block, they'll be treated anyway.
I'm an interventional cardiologist, so naturally with very little or no knowledge of EP, I would say. So I was very fascinated by the slide that you could do a left bundle pacing without an EP lab. So I hope you have a lecture tomorrow regarding that.
Yes.
So anyway, then I'll keep quiet. I'll watch the lecture tomorrow.
Just have a couple of comments on the structural area. The towers get, implants are not very deep. We're keeping it more shallower. The valves are getting better. So the CHP and left bundle branch block, which we used to see more frequently 2 years ago, we're not seeing that anymore. It's much, and I would agree absolutely with Zach. If I get a patient with aortic valve disease who's LV dysfunction and who's already got an LVBB, no sense in sending the patient home. We would implant the pacemaker at the same setting, maybe a couple of days later, and then send the patient home.
What do you feel is the role of EP study to look an HV interval if patient has developed new onset LVB and take a call?
Well, I don't think we do it once you get an LVBB. I'm not sure, maybe the electrophysiologist would do, but in a routine patient, when you get a post-TAVR, just be sure to remove the pacemaker. We used to do it. We used to pace and check the HV interval on the table and then pull the pacemaker out, because you don't want that right ventricular pacing catheter in for too long. But in the presence of LVBB, I'm not sure. Maybe Gaurav or Zach could tell.
Let me recollect one of those cases where what you said. You see, we have a concern of a new onset left bundle branch block with or without the PR prolongation, with or without axis change. However, what we have noticed in a couple of our cases of TAVR, post-TAVR, if during the procedure, if there was a CHB during the procedure, and then it recovered, okay, I think they, even with a narrow PR and an LBBB with a normal axis, I think they have a tendency, because we have had 2 such cases. Yeah, we were relaxed, okay, because it is considered that it's a transient phenomenon, but it was a new onset LBBB, right? And then they developed, fortunately, before they went home. One case before went home, another one came here for the follow-up without symptoms, but intermittent high degree AV block. So Anindya wrote it up, actually, where, as you said, that's a major concern. How do we tackle this LBBB? I don't know whether that HV interval calculation for all the patients, pre-discharge, I think it is more invasive. It may not make sense. But one hint is, if there is a transient AV block complete, okay, we are very cautious, because we had 2 such cases.
Even in the absence of a transient AV block, you produce injury to the septum. There will be edema, and subsequently how much fibrosis will happen, you don't know. So that is sort of an unpredictable thing. So I don't know whether an acute measurement of an HV interval is going to really help.
And certainly to Dr. Ajit's point, it's changed a lot over the past really 2 to 3 years. Nitinol self-expanding stents certainly had a higher risk of later progression, advancing progression of AV block than the more recently used and developed valves that typically don't continue to demonstrate those outward forces. Just to briefly though point out that in HV interval, you can go back to foundational work in EP. So this is Mel Scheinman's work. So generally when we have a normal HV interval, it's 35 to 55 milliseconds. If you have a left bundle branch block, it hovers around median 70 milliseconds, 70 to 75. If your HV interval is greater than 100 milliseconds, the risk of having further block is very high. So if you see a very high HV interval, you can be certain that it's a problem. But how you interpret a 70 millisecond interval with no block, I think I would make the same call that Dr. Ajit said. If you have LV dysfunction, that's a concerning patient.
So thank you, Gaurav, Whitney. So ladies and gentlemen, let's go to the dinner area, and thank you for coming.